So, some of it's going to be some background information, kind of boring, but we'll get into like the importance, of why we're teaching you this, why we're doing it. And it's, kind of funny in the military because we're supposed to, PAs are usually like the first line person for trauma, or like your first, really the first level of care. You might receive like a combat medic and then a PA. And so we're supposed to be the experts in it, but unfortunately, a lot of phase 2s aren't trauma centers, or they're like level 3 trauma centers, so you don't see a lot there. Only level 1 in the military is going to be BAMC, so yeah, and it's so oversaturated there, you'll see trauma, but probably not get your hands on a lot of it. So it's interesting because we're supposed to be in charge of like the TC3 program, the experts in our units, and unfortunately we may or may not get a lot of experience in trauma prior to being out there and actually having to deal with it. So we're going to go through a lot of these. Some of it may or may not make sense. It'll make more sense when we do our trauma, like our Emed 4, whatever that lab is we have all day. It's only half day, we split the class in half, but that's when we're going to utilize a lot of this and go through our primary and secondary surveys, run through some trauma scenarios on some mannequins, and then we'll have stations for all the different airway things you guys are going to see in the slides, or airway adjuncts. We'll do like tube thoracostomies on some mannequins, which aren't the best models, and they're kind of used and abused, but it does at least give you a general idea. And then when we have our ATM lab at the end of the semester, we're going to do it on live tissue, so that'll be on the K-prime model, or the goat. All right, let's get into it. There's the book you guys have probably never opened or seen. This good old tin nollie. And then here's our objectives. And really the same objectives we always have. So we'll talk about epidemiology. This one we're going to go into trauma systems and how we kind of establish them. Not something, we're going to test you on really, but it's good to know a little bit of background of how we actually identify trauma systems and then trauma levels of care, like your level 1s versus level 2s versus level 3s. And then we'll talk about our primary, secondary survey and some of the adjuncts we perform during those. These videos don't work anymore. I should probably delete the slide, but it's lazy. And some of them weren't that great. So, and we do it, so when we're talking about civilian trauma, which is mostly what this lecture is today, we base it on advanced trauma life support, so it's called ATLS. It was designed by the American College of Surgeons a number of years ago, and really what it is if we go in a systematic fashion during our for all of these trauma patients, which is our primary and secondary survey, the data has shown we've improved mortality by following this systematic approach. So most of you will attend advanced trauma life support, so it's like a 3-day class, 2-day class, depending on where you're at. And it really just goes through your primary, secondary surveys, your tertiary survey, and it does a good job of doing some hands-on and how you would run a trauma. But here's what we'll start with, and this is really our primary survey here, and kind of our takeaway point for all of this lecture is going to be how we go about systematically treating these patients. And really what we're looking for are those, quick causes of death in these patients. So any airway obstruction, tension pneumothorax, cardiac tamponade, hemopneumothorax, flail chest, and if we can identify those and treat them early, we have a good chance of survival or improved mortality in these patients. So we really start, and this is where it gets kind of debatable on here. So advanced trauma life support doesn't add that extra rapid blood sweep in there first. So like in a surgery class, they'll probably omit that step initially at the beginning. And we usually like to evaluate for that, especially in the emergency room, and especially like on in a Role 1 or on a battlefield casualty, because you don't have it, you may or may not have any blood, so it's something we want to make sure we control first. But we move into our airway assessment. Do they have a patent airway? Consider C-spine, depending on the mechanism. And then we go to breathing, circulation disability, and then we expose, prevent hypothermia. And then we do our EFAST exam on these patients during our primary. It's an adjunct to our primary survey. And then if we get them stable enough, we can send them to the donut of truth. All right, so here's our warm-up case. You got a 45-year-old dude. He was an unrestrained passenger in a high-speed accident. He was ejected from the vehicle. Patient's intoxicated but alert, talking and belligerent. EMS brings the patient in with C-spine precautions on a backboard. His vitals are, like stable-ish, right? And maybe a little low on a little soft on the blood pressure, but still not hypotensive, a little bit mildly tachycardic. And then he's not complaining of anything on exam, but you see evidence of head trauma, multiple facial lacerations. And as we go through this, we'll kind of discuss what our process is for taking care of these patients. But as you can see, trauma is pretty common, it's the most common cause of death in younger age patients or the younger population. It's important that we understand how to treat these patients and what our process is. Even if they survive the trauma, they're going to, a lot of them will have sequela for the rest of their lives after this trauma. So, for trauma, we like to say that there's like a trimodal distribution of death in these patients. So, initially, a significant percentage dies at the scene or before anybody even gets there. And that's usually from like massive brain injury, massive hemorrhage somewhere, or large vessel injuries, and then massive chest injuries. So those, we can't really do anything about those ones. And then we have that, that second phase of the injury, which is those patients with life-threatening injuries. And if we do something in the first hour or two, we have a good chance of saving those patients' lives. So that's kind of where we come in here with our trauma assessments and evaluations, making sure we get these patients to the right trauma center. And then our third distribution is later in the hospital, and that's usually from infection or multi-organ dysfunction that kills these patients. All right. So here's just some background. We developed, the U.S. developed a trauma care system, and really we wanted all the states to kind of model them similarly. And really what it's saying is, like, if you're going to be a level 1 trauma center, you have to have enough personnel and resources. You have to have all of your specialties and subspecialties 24 hours a day, 7 days a week. So you need like neurosurgery, you need your trauma surgeons, you're going to need your orthopedist, and that's really what kind of demonstrates what level of trauma center. And then there's there are some criteria. You got to see a certain amount of patients every year, which I think is on this slide. Yeah. So you got to have 1,200 trauma patients a year, and 240 admissions, and then injury severity score, which we won't talk about much, but it is a score that we can use, looking at 6 different body systems and what sort of injuries they have, and we can calculate a score for them. And then you need to have a surgical care or crit surgical care service. So usually, we call it trauma surgery, or I know at BAMC we call it like surgical trauma or the STICU. And then they have to have training, residence, education, research activities that all go along with being a level 1 trauma center. So, we start with, all our trauma centers, we start with like a multidisciplinary exam, and we'll go into kind of how we set these teams up. And it's going to be a lot different than what you would see like in military medicine, which we'll talk about in a couple lectures. But really, we need smooth transition from ED, radiology. They need to be able to get to an operating room suite. And then we have to have some sort of like post-op ICU, which we call the STICU of BAMC, or some places call it SICU, surgical ICU, for recovery in the post-op period. And then you're going to have 2 phases really. They're pre-hospital and hospital. So we're not going to talk much about pre-hospital in this lecture. We'll cover a little bit more in the military medicine lecture, but this is going to be really conducted by EMS. So they're going to, if anybody remembers the like March algorithm, anybody's done TC3 and trauma before, and that's really a little bit more simplified approach with the resources you have in the pre-hospital period, but it's like a pre-hospital primary assessment. And today, what I showed at the beginning was more of like a hospital primary assessment. So this one's just massive hemorrhage, so stop any bleeding, make sure they have an airway, respiration, circulation, and hypothermia prevention. And then here's a trauma system entry criteria. And this is really when you have your emergency medical system in your pre-hospital phase, they kind of decide which patients are going to go to which level of care. So do I need a level 1 trauma center? And if I do, these are the rough criteria that would make us divert to either like a level 1 trauma center versus level 2 versus level 3. And a lot of this is handled by like, some sort of medical control in EMS service. Here we call it MedCom in South Texas. But it's, some of them are pretty simple, straightforward, like anybody with trauma, and they have hypotension, they've got a, TBI or decreased GCS score. And then we look at like penetrating injuries, gunshot wounds, stab wounds, any sort of neurovascular compromise. So, do I suspect that, do I not have any pulses in certain extremities, amputations, proximal to the wrist, I guess, or ankle. So, because you could lose like a hand or foot and still not go to a level 1 trauma center. And then some of its mechanism of injury, so and that's up to EMS, whether there's like 12 inches of passenger compartment intrusion, major deformities on the vehicle. And those are kind of subjective, because I've had them bring them, I think we were level 3 at Fort Hood when I was there, and they bring in pretty bad vehicle accidents with the patient perfectly fine, which is probably why they brought them. They didn't meet the criteria. Anybody that's ejected is going to go to a trauma center. Fall from 20 feet, that seems kind of high to me, but I guess that's the rough standard and grading of whether it's going to be a trauma versus some other injury. But 20 feet. Then there are some other ones, like looking at, pregnant trauma patients are usually going to go to a trauma center, a level 1 trauma center. But in the pre-hospital phase, and we'd like to have some sort of notification other than, hey, we got somebody in an MVC and we're on our way. So we like to use the MIST criteria, which is, if people remember, like if you were ever in like Iraq and Afghanistan, we use a MIST report there as well. So we use it here. Not every trauma system does, but here in Bexar County we use this. I think all of Texas uses it. So really we like EMS to notify us what the mechanism is, what injuries. So if it's I got some sort of deformity on the thigh or suspicion of a fractured femur, what signs and symptoms they're having with it, and then any treatments that they provided in the pre-hospital phase, we like to know before they come in if they have time to notify us. And they usually do a good job with civilian EMS here. And then some of the things we like to know, if EMS can, sometimes they can't because the patient can't tell you anything, but when the patient isn't, if they're altered or unconscious, it's important that EMS tries to get any sort of history that they can. So, things we like to know, are they intoxicated? Do they ingest anything? Any pre-existing conditions? And important ones are anybody like on anticoagulants or something we like to know, just so we can evaluate or treat anything that might be related to increased bleeding risk if they had a trauma. So sometimes we get this report, or we're able to, and sometimes not, unfortunately. But here's where we get into our job. So usually they notify us with hopefully 5-10 minutes, sometimes less. And what we need to do is establish our team. So this is normally done beforehand, but at BAMC we have assigned teams when we show up. In most emergency rooms or trauma rooms, we do this at the beginning of the shift. We decide who's going to take what role. And we'll kind of show some pictorial demonstrations. But normally you have a team leader, you have usually an airway provider, and then you get ideally you'd have a provider on the right side of the bed, provider on the left side of the bed. Then you have your nurses and medics or techs who can do IVs, push medications, and then you have a scribe as well in an ideal world, which is a lot of people, right? If you've ever dealt with like a roll one before, that's a ton of people just for one patient, but that's how we establish trauma centers, because we have enough of that personnel to be able to take care of them. All right. So we start our hospital phase with our initial assessment. That's when we do our A, B, C, D, E, F, G, all that fun stuff. I feel like we add like a new letter every year, every year or two, that, I mean, or somebody else adds it on their evaluation to try to make it more simple, but we'll go through that. Here's how it should look in an ideal world if you have enough personnel. So you got your team leader, usually at the foot of the bed, kind of directing traffic. Hopefully at level 1 trauma centers, everybody's well-trained, they're well-oiled machine, they've gone through this many times. But you have an provider on the right side of the bed, or what we have exam 1 on there. And that patient usually gets clavicles down on the right side of the bed. Exam 2 gets clavicles down on the left side of the bed, airways, clavicles up. And then we have our additional support there with our RNs, medics, and they're usually getting IVs, pushing medications that we need, and then we have a scribe there as well. But this is how most trauma rooms are going to look that you guys work at. Now, what's important is, I can speak for the Army, I don't know about the other services, but you're going to be usually a battalion PA first. It's going to be up to you to establish this, to practice this at your aid stations. You don't want to practice for the first time or train them for the first time in an actual trauma patient when you're deployed somewhere. So it's important that you guys carve some time out so you can actually train these people, get them up to speed. And this is like, if you use this many in a roll 1, like that's, at least probably a third or sometimes a fourth. Sometimes that's all the medics you're going to have right there. And I forgot to mention RT, so respiratory therapy at the end of the bed as well for airways, so they can run that later. They can help with suction, things like that. And then here's what it looks like. I think this is BAMC. This one's definitely BAMC. So you can kind of see how crazy it is, how many people are there. Sometimes it's important that we have somebody there controlling the number of people in the room, so if they're not actually partaking in the medical care, then we may or may not kick them out of the room, because you can see how crowded it is with just one patient and all that staff. But here's our primary survey. This is what's important. So we start our primary survey. Well, let me go back a second. Let me see. Maybe on my next slide. No, let me go back a second. So what it looks like in the trauma room, we'll go back to this one. So really when we start our primary survey, EMS wheels the patient into the room, and normally your team leader or somebody at the door is like, hey, what's your name? So if they can talk and tell you their name, we got an airway, right? So that's, important. And then we do depending on where you're at, we do an EMS report. So some places, like at BAMC, we transfer them to the bed first and stabilize them. Other places, you'll get an EMS report before we transfer them over from the EMS stretcher to our bed. And some of it will depend on like how in extremis that patient is in and when we do that, but that's kind of how the process works initially. We wheel them in, we make sure they have an airway, we transfer them, and then we do an EMS kind of timeout, and they give a quick report of everything that happened to that patient, all the interventions they did. Any history they may or may not be able to provide, they'll give it then. Then we transfer them over and begin with our exam. So your airway person everybody's working simultaneously. So we talk about the primary survey in a sequential fashion, A, B, C, D, E, F, G, which is what you would do if you were like by yourself going for. The reason it's important is we want to control that airway, and if they don't have an airway, we need to fix it before we move on to the rest of our primary survey. In an ideal world like this where we have enough personnel, everything's going on at once. So somebody's checking breathing, somebody's checking circulation, the airway person's checking disability after they secure the airway, and typically we're doing our quick primary survey head to toe, and we're just evaluating for any significant injuries we can fix right now. So we go airway, breathing. So do I have equal rise and fall of the chest? Do I have lung sounds bilaterally, clear lung sounds? Then we move into circulation. If we can get a blood pressure, great. If not, we're checking pulses in all 4 extremities. Do I have pulses? Are they weak, thready? are they full and equal bilaterally? Are they 2+? Then we move into disability, which is where we get our GCS. We'll usually get like a pupil size as well, and we'll check their eyes. And then we move from there into exposure, so we get the patient trauma naked, which we've probably got them trauma naked already by now. And then we want to make sure we prevent any hypothermia, and then we move into like our EFAST exam. In real life, all of that's happening at the exact same time. But so when you're like reading test questions or looking at it for an exam, look and see if the airway is not secured, then you probably need to go back and intubate that patient or secure the airway. Or if you haven't dealt with breathing yet, you probably need to address that, okay? All right, and here it is. So this is what we're looking for, kind of what I talked about already. This just gives you a little bit more in-depth view, but really everything I said. So we're going in a sequential fashion. Any massive bleeding we see, if there's massive extremity hemorrhage, we need to make sure we're taking care of that initially, or just throwing a tourniquet on there. And that's where you'll see it differ from advanced trauma life support. They do A, B, C, D. And then during their C, they might be looking for any sort of massive hemorrhage. What do we do when we find these? So airway, if they don't have a secure airway, we need to establish one. So normally we'll do a definitive airway with like endotracheal tube intubation, which we'll cover during our next lecture, all of our airway adjuncts. But for massive hemorrhage, we usually use a tourniquet if we can. So if it's in like a junctional area, which is what we kind of call the one of those like axillary regions, your groin, places you can't put a tourniquet, we want to pack those wounds, some sort of hemostatic agent, extremities, we need to put a tourniquet on there. And the standard one in the military is the CAT tourniquet. This is standard in most hospitals too. So in most trauma centers, you're going to have a CAT tourniquet by the bedside. Has everybody used a CAT tourniquet before? Trained in it? I think everybody does, right? All the services kind of practice TC3 stuff, TC3-ish. We have Coast Guard in here? No? Yeah, I don't know about the Coast Guard. They probably don't. All right, so moving to our airway. Like I said, we usually ask the patient their name. If they can tell us their name, we likely have a patent airway at the moment, so we don't need to do anything further. But that head of the bed or that airway person is, initially checking airway patency, and then they're inspecting for any sort of foreign bodies. Do I see any teeth in there? We check for maxillofacial fractures, so we kind of palpate the face for stability. If we need to open the airway, we perform a jaw thrust if we're concerned for any sort of C-spine injury. Most patients in the States should arrive with a C-collar on them if they have the right mechanism of injury. If not, then we need to establish that. And then we can insert some other airways that aren't definitive if we need to, like an NPA. We usually don't use, if they could tolerate an oropharyngeal airway, usually we're just intubating them and not using those. And then here's our NPA. So this is an easy airway adjunct. The patient can have an intact gag reflex. They can be awake, alert, and oriented. I know a lot of you have probably done them on each other. That used to be a big thing we do during training. Has anybody gotten an NPA before? Yeah, so yeah, quite a few people. It's not that bad. Yeah, I think you all should try it once, in my opinion. All right. So when we're doing, when we're dealing with trauma, it gets a little bit tricky because we have to, like if we're going to intubate them, or if we're going to roll that patient, we have to usually use a two-person kind of inline stabilization technique. It's usually one person's, at the head of the bed, and they have their shoulders and their head kind of sandwiched in between the proper way we normally do it now. And then anybody with GCS 8, intubate. So at 8 or less, we need to intubate that patient. And then we always want to consider any sort of other, like alcohol-induced, any intoxication, and consider that we may have to take their airway at some point, or they could, maybe risk harming themselves. Sometimes when you have, especially with head injuries a lot, you have patients that aren't going to be very cooperative. They might keep trying to get out of the bed and they're altered, so it's something we have to consider and deal with. And here's what it looks like when you're intubating. So you see the guy on the left there, he's providing inline stabilization. So we normally take that seat collar off the patient while we're intubating. Now we usually, or at BAMC, we actually grab their shoulders and we sandwich their head in between. So it's a lot more awkward. You're like at the patient's crotch if you're that guy and he's trying to intubate. So it's kind of an awkward position. If you're providing the manual C-spine control. And that guy looks like he's super, I don't know, he looks like he's like kissing the patients there. I don't know about that. I don't know about that technique. I wouldn't want to be there. But, we do have, there are always, difficult intubations, and especially in trauma patients, especially with any sort of maxillofacial trauma or when they have C-spine immobilization. So we need to be ready. A lot of trauma is preparing all of your equipment, so having your suction readily available. You want to have a backup suction just in case one of them goes out on you. So we want to prepare appropriately in case that we see any blood or vomit in there. We might need to suction that out. Now, most trauma centers, or all of them, we use video laryngoscopy, which is kind of nice. And like at BAMC, it can be like projected on the screen. So then you know that, like, if you're the trauma leader, you know that you have a secure airway because you were able to watch the tube go through the vocal cord. So that's usually the standard of care. Unfortunately, you guys don't have video laryngoscopy at a roll 1, so it's important to also train with direct laryngoscopy as well. And then we use the RSI technique for intubation, which we'll cover in the next lecture, and that's rapid sequence intubation. And that's just a systematic process we use so that we make sure we go through all our steps to sedate the patient, paralyze the patient before we secure that airway. And then there's always our cric. If they have severe maxillofacial trauma, we can't get an airway. Here's what video laryngoscopy looks like. So that's a glide scope. It has a little screen there. We have some that we'll practice with during our lab too. So it's kind of nice. You can visualize your airway or your vocal cord. You can watch the tube go through it. And other people can watch as well, so we all don't have to sit there and think that we don't have an airway or maybe it went in the esophagus. The difference between if anybody's used direct laryngoscopy before, video uses hyperangulated blades, so it can be a little bit of a learning curve at the beginning if you're used to direct laryngoscopy. But once you get the hang of it, it's way easier to use. So with the hyperangulate, you don't have to bend down and look in the patient's mouth or anything. You can just manipulate it all right there. So it's angled a little bit steeper on there. But once you get used to it, it's a lot more convenient. Here's some other, this is King says, I've never seen this one. I don't think anybody ever used it, but this is like a little pocket, not pocket, but a smaller version of those video laryngoscopies or video scopes. So we have glide scopes that look like that too, and that's what we'll practice with. So they're similar during our labs, and it's something, when you're in your units, if you don't have one, it's something, I would try to order if you guys have the funding for it. All right, so we're establishing our airway management, and they have a seat collar on. So after we control airway, the question is, do we need C-spine control or not? Can we clear that cervical spine? So some of the criteria we use to remove it is our nexus criteria, which we'll talk about during our spinal trauma lecture and how we can clear those patients. But it's just a useful algorithm or useful scoring tool that we use, so we can say that patient doesn't need C-spine control. All right, next we're checking breathing, ventilation. So look at the chest. We're auscultating. We're palpating the thorax. We're looking for, feeling for any crepitus. We're looking for any paradoxical movement of the chest wall, unilateral chest rise or fall, any absence of breath sounds on the chest while we're auscultating. And during this process, if we find anything, so if I have unilateral movement of the chest wall, I have decreased breath sounds, then we need to treat that. So that's likely a pneumothorax, hemo or pneumothorax or some combination of both. So we need to fix that immediately. So normally we'll do, if they're tension pneumothorax, we normally start with needle chest decompression. But in like a level 1 trauma center, we usually use our fingers. So we just do a finger thoracostomy first and cut it open so we can put a tube in there. But that's something we need to treat before we move on to our next step, our circulation step. And then what is this? Yeah, right main stem intubation. So that tube is too deep in that patient. So that's something we always want to evaluate when we intubate the patient. And we need to look at how many, like your endotracheal tubes have measurements on it. So usually like 23 at the teeth is a common one in adults. So we want to look at that and make sure we haven't like hugged our ET tube. And it's very common, it happens because there's a lot going on. Patient has, multiple multi-system trauma, so there's a lot going on. And sometimes, you establish that airway and then you push a little too deep, and this is what it looks like. So you see, that hemithorax is like kind of opacified there. And then you see that tube going down the right main stem and only inflating that one lung. So we just pull the tube back at that point. You should probably deflate the balloon first. All right. So, wrong way. I was going to say, I think I already talked about that. All right, other things we need to think about, and I kind of already said it. So tension pneumothorax, we do a needle or finger thoracostomy, chest tube for pneumos or hemothoraxes. And then if they have some sort of like what we call a sucking chest wound or some sort of penetrating trauma to that thorax, we place an occlusive dressing on there. There's like a million different types and brands. This one has, like some one-way valves on them to help relieve some of that air, but really we want to seal it. So even, a piece of plastic and tape around it works as well. All right, and then moving on to circulation. So if we had any massive exsanguination and we placed a tourniquet, we need to reassess, our intervention at that point. And then we need to address any other wounds we find or any other bleeding. And really the big ones are going to be those junctional areas, pelvic fractures, things like that we're looking for, any like axillary injuries or penetrating axillary wounds in those patients. We need to use some sort of hemostatic agent, like combat gauze is a very common one that we use, and it works well. And we'll practice on how we actually use that dressing, because we don't just like open the package and throw the whole thing in there and hope it works. But we'll get into that during our labs. And if it was placed pre-hospital, once again, we need to reassess that intervention. All right, so we also want to check their overall hemodynamic test. So do I have a blood pressure? What's their pulse rate? How's their skin color looking? How are my peripheral pulses? We can also look at pulse pressure. Is it narrow? So that can be a sign of, hemorrhagic shock or another indication of hemorrhagic shock that we need to address. And then level of consciousness is a big one as well. We want to look for any sort of other injury. So that's a seatbelt injury there. So, in that hypotensive patient, you don't have any sort of extremity hemorrhage or other hemorrhage that you can locate, then you want to consider that they have some sort of intra-abdominal hemorrhage and they're going to need to go to surgery stat. And then here's our wonderful classes of shock. It's something, I don't know if you guys know or not, I can't remember what's on your test, but it's something that, we don't sit there in the hospital like, I think he's in class 3, hemorrhagic shock. It's something to understand, like conceptually, and as you lose more, a larger amount of blood, you start to see changes in their vital signs. You'll start to see initially, usually they start to get tachycardic, and as they progress, you'll see that blood pressure start to decrease, and they'll get hypotensive. They'll start to narrow their pulse pressure with, the more blood they've lost. Another thing that's on here is their mentation. So they'll start to initially get kind of anxious, and they like feel like they're going to die, and then eventually they'll get altered where they're not able to converse with you. So that's another sign of like a worse hemorrhagic shock, or worse class of hemorrhagic shock. Circulation, we want to establish 2 large bore IVs. So usually that's 2 18 gauges in each of the ACs. If we're unable to do that, we can do like an interosseous needle, so we can put a needle in the bone. Unfortunately, they don't flow as well as our IV catheters or other means of establishing access. So it's something that we don't use. It's like basically an adjunct to get us, a better IV. Or if we need to intubate quickly and we need to paralyze them, it can be utilized for that. But it's going to be difficult to push large amounts of fluid or blood through an intraosseous needle. They have a slower flow rate. That's why the picture up there, that's your easy IO. That's why they have pressure bags on there, because if you're using an IO, you're going to need a pressure bag on there. And then what is this one here? What kind of line is that? It's a central line, right? So that's a subclavian central line. So that's a very large bore catheter that we can push large amounts of fluid through. I think blood with a Belmont, we can push like a unit of blood, I think in under a minute, and that one are right around a minute. So that is the ideal access we would like if we're having to resuscitate that patient, but it's also more invasive. Then you run the risk of looking at that location, like you can cause a pneumothorax in those patients if it's not done correctly. All right. So, most of the meds can be given through an IO. Like I said, you got to use a pressure bag. You can't use, large volume resuscitation through your IO. When we're resuscitating these patients, if they've lost blood, we need to give them blood. So, normally for certain conditions, shock and things like that, we can use, crystalloids, as long as it's not hemorrhagic shock. But in these patients, we want to be careful with any lactated Ringer's normal saline, because we can dilute that blood and cause a coagulopathy and worsen that condition in the patient. So if they've lost blood, we need to give them blood. And then massive, we do have like massive transfusions. Most of them are considered 10 units or more as massive, our massive transfusion protocol. And that's really that's like a temporizing measure, because ideally, we need to get them to a surgery suite so we can control wherever that bleeding is coming from. And sometimes it'll be like polytrauma, so you've got intra-abdominal bleeding, pelvic bleeding, you might have amputations or other injuries that require massive blood products, or it can be something inside the abdominal cavity that's very difficult to get control of, and we might need to activate like our massive transfusion protocol. If we suspect any sort of pelvic fracture, and usually that's, during our exam we palpate and we feel any sort of instability, we'll put a pelvic binder on those patients. And once again, so any trauma is going to cause that coagulopathy and have that defective, clotting, platelet function. So what we like to do if we're doing massive transfusions is do what we call a balanced resuscitation. So that's our 1-to-1-to-1. So we got our PRBCs, our plasma and platelets. And then if you guys remember that triad, we have our acidosis and hypothermia as well, and coagulopathy. That's our lethal triad. So we're trying to correct that as quickly as possible. A lot of patients don't get a balanced resuscitation, unfortunately, because it takes a little while to unthaw those products like our plasma and platelets. So a lot of centers are getting, unfortunately, we're only using PRBCs. A lot of places are switching to whole blood, which gives you a balanced resuscitation. So some places emergency release is going to be whole blood, which is great, and they get a more balanced resuscitation. I know we switched to whole blood when I was at Fort Hood, and we did we had to do a study like for a year before, just assessing whether they got balanced resuscitation. And it was funny, after we looked, we were like, nobody got balanced resuscitation. We assumed, like, because we're stabilizing the ER, we assumed they go to surgery and they start to get a balanced resuscitation. And it wasn't happening there either. We're like, oh, that's not good. So we switched the whole blood, and we solved that. But, you know, it was a level 3 trauma center, so we don't do a ton of trauma that requires transfusions. I think it was like 15 or 20 in a year. There are other adjuncts like Reboa, which is, did we talk about like resuscitative thoracotomies, or you guys talk about that, where we open the chest up, or the left side of the chest up, do a thoracotomy so we can cross-clamp the aorta, and we can control any sort of bleeding using that method. So it's a very invasive procedure because you're going to open the entire chest up, sometimes both sides, and you're going to use some spreaders to open it so you can see the heart, you can cross-clamp the aorta. And we're trying to clamp the aorta so we can keep blood going to the vital organs like your heart and your brain. So somebody came up with this thing called Reboa, where we stick a long catheter, and it goes in your femoral artery, and it goes up, and you inflate a balloon to help basically to stop all of that blood going to the lower extremities in your abdomen, and then you can just keep those vital organs perfused, like your heart and brain. They haven't shown great, they don't work as well as we thought. I mean, they work, but we have significant reperfusion injuries afterwards, so something kind of fallen out of favor. It's still in that TC3 protocols, but it's not something we're using very often anymore, so we won't get into it. Trauma patients, we want to make sure they all get TXA, so we want to get some sort of antifibrinolytic on board, so usually 2 grams TXA. Studies show it's best if they get it within the first 90 minutes. It has the most effect, and then up to 3 hours later as well, which is came out of the most recent studies for it. So everybody's getting that 2 grams TXA. Then moving on to disability. So this, you know, we're assessing the level of consciousness using our GCS score. We're looking at pupillary size, reactivity. We usually call it out. The airway person does like 3 millimeters equal reactive. And then we're assessing their motor function. And really it's, can you move all four, can you move all your extremities? And then we're assessing the GCS score. Anybody GCS less than 8, we're going to intubate. And then here's our GCS score. I'm not going to get into it because I know you guys, I think I've seen it on almost every Emed test already, right? Yeah, so we'll add it to another one. I mean, you guys should have it down by now, right? All right.
No, this number.
I still got time. All right, so disability, we want to look for any sort of significant head injury, TBI, that's what we're looking for during this. Because those patients, as we'll talk about during our brain injury lecture, we have to keep most of their parameters in a normal range. But their blood pressure, we want to keep it above 110. We don't want any episodes of hypoxia. So it's something we need to identify early in those patients so we can prevent any sort of secondary injury from under-resuscitating them. But we usually say like everything, normal everything, so normal tensive, euglycemic. Everything needs to be in the normal range. We don't use like prophylactic hyperventilation. You will still hear about hyperventilation to avoid herniation, but it's kind of fallen out of favor as well, especially if you have a neurosurgeon, then it's something we're going to get them if we suspect any sort of herniation. All right, and then we need to get the patient completely naked so that we can roll that patient over and evaluate for all their injuries. So, at this point, if we haven't stripped them naked, we will. This is usually already done. And this is so we can evaluate that posterior thorax and that spine, and we can log roll that patient. So we usually do that closer to the end of our primary survey. But important things, if you suspect, you have any like GSWs in the anterior thorax, it's important we lift all those arms up, we check those axillary areas, because those injuries can kind of hide on there, or those exit wounds can hide, and we want to make sure we evaluate them appropriately. We're then running down their entire spine on the back, so we're looking for any step-offs, deformity, any tenderness on there. And then we do a quick rectal exam, checking for gross bleeding and rectal tone. We're checking, like I said, same with axillary, we're checking the perineum as well. We're making sure we don't have any sort of exit wounds there, any GSWs in that area. I had he's like an Iraqi, but he wouldn't roll over. He was always on his right side, but he was stable. He had GSW to like one of his buttocks, and I'm like, why ain't this dude rolling over? When we rolled him over, the exit wound was right in the groin, and massive bleeding when we rolled him. I was like, roll him back, roll him back. it was tamponaded on there, so it's important to check all those areas. All right, and then our EFAST exam. So this shows it, at the end of the primary survey, which is what you're going to do ideally without enough people. Normally, the EFAST is happening right after that patient is transferred over. If you have enough people, usually that'll be a good job for you guys. Like in phase 2, like I'll usually have you guys because a lot of places, especially if you have a residency, you're not going to get a lot of hands-on the traumas because they have to meet a certain number of procedures and traumas. So I usually try to at least get your foot in the door by having you guys as the EFAST person. So you're normally doing this in like bent down weird while they're stabilizing the ABCs. You're usually checking all of your quadrants or all of your areas with the EFAST exam. But we're looking for any sort of, really any intra-abdominal hemorrhage and there are signs of hemorrhage. So we're looking at the right upper quadrant, left upper quadrant, suprapubic area, and then we're looking at the heart for any sort of tamponade, and then we look at the lungs for our enhanced FAST exam. So we check for lung sliding as well. And our entire block 5 is just going to be all scanning each other for the entire time. And then if they're stable, we can go to the CT scanner. But the CT scanner is where patients go to die. So that's how the ideal primary survey works. So hopefully you guys will get to see this at phase 2. We're definitely going to practice it during our labs that we have and during our advanced trauma management lab as well. And let's take a 10-minute break. Be back in 9. Have a high mortality rate if we don't identify them. So severe head and spinal trauma. That's why we're doing our GCS score, and we're doing a thorough exam of their head during our primary assessment, so we can identify those severe head injuries because it's going to affect our management if we need to take them to surgery just for like some sort of intra-abdominal hemorrhage injury, or if we also have to have some sort of neurosurgeon there as well to address that severe traumatic brain injury that they may have. So it's important we identify those early if we can. Sometimes we'll look at the priority, so they might have some sort of brain bleed or massive trauma, but we don't see any signs of herniation, and we have to stop the bleeding in the belly first to keep them alive. So sometimes, we may take them straight to the operating room, depending on what our imaging, if we can get it in time, shows us. What do we see here? Yeah. So this is signs of injury, some sort of brain injury. So it's something we need to, it'd be pretty hard to miss this on an exam, but it's something we need to evaluate for during our initial primary survey, looking for any of these. We also look in their ears during the primary survey as well, just looking for like an hemotympanum and making sure they don't have any like basilar skull fracture. Tension pneumothorax, open pneumo, massive hemo. These all need to be addressed during our primary survey and corrected. We'll talk about it during our thoracic trauma lecture, but a lot of the patients that have isolated like thoracic trauma that requires a chest tube, a lot of them actually don't need to go to surgery. The chest tube is a definitive management if we treat that appropriately. And once again, tension pneumo is clinically diagnosed. It's not something we require imaging for. If you have signs of tension pneumothorax, we don't need to wait for the EFAST exam. We don't need to wait for the chest X-ray. that's something we need to treat immediately. So those patients are going to get, needle D or finger thoracostomy followed by a chest tube. Cardiac tamponade is something we're evaluating for as well. This one usually does require some sort of either clinical suspicion or ideally it's going to be our ultrasound diagnosing this. But I know we talked about it a little bit already. So we get blood, in that pericardial sac, and your heart can no longer appropriately pump. So it leads to all of these other signs you would see on exam, and it is life-threatening. So that's something we need to fix as well. If they have like a stab wound in the area, we need to, evaluate for that. If they have like blunt chest trauma, it's something we need to consider. And there's no like set amount of fluid that causes tamponade. Everybody's heart's different. So it can be, something as small as like, 60 to 100 milliliters, or it can be more massive. But we need to use our EFAS or our ultrasound to diagnose this. And then if we have that Beck's triad, we need to do something probably more acutely, and then instead of waiting for dealing with that later. A lot of times in these patients, especially in the trauma room, they're going to get like a thoracotomy at that point. Here's our tamponade. So that's pretty large on this patient. You see all that fluid there at the top surrounding the heart, and it's affecting its ability to appropriately squeeze. So see it on the EFAS. We can do it, temporizing is like a pericardiocentesis. Ideally, they'll get some sort of like thoracotomy or sternotomy so that they can address that more definitively. And this is what typically happens in trauma rooms. So we'll get a thoracotomy. And I think I have a video here that kind of shows you how horrifying it is. But unstable patients, if we have suspicion of that tamponade, we're going to open them up usually in the trauma room. Other candidates that we use it with are going to be patients that come in with like a palpable pulse and then they lose pulses. That's going to be one of our indications for a thoracotomy if we haven't identified any other cause for that injury. And so even if we have, I guess I should say. So that's when we open the chest, we clamp that aorta, and then we deal with any sort of other injuries that we may see. Sometimes they can have like a lacerated pericardium. They might have, cardiac tamponade on there. Patients where this doesn't work great is if they're pulseless, they had no pulse in the field. If they're, asystole is a presenting rhythm, any like prolonged CPR, so they say over 15 minutes, or any other massive non-survivable injury that's not, it's going to be futile. We still likely do it, but technically, we don't, they don't meet the criteria. So here's what it looks like. I don't know why that person has a watch on. That's why you don't wear watches when you're in the trauma room. But as you can see, they they open up that one side of the hemithorax. So we incise from the sternum all the way down to the bed. We use those rib spreaders, which you kind of crank with that little knob you see on the bottom right, and it opens up that chest. And then we need to get down to the aorta, cross clamp it. They're obviously have significant bleeding in there, so they're trying to clean that out first, or give them a good visualization of what they're dealing with. We can also do CPR through it, so really we're just squeezing the heart with our hand. That's the CPR you're doing at that point. You can also shock them. It looks like two little spoons on the paddles, and you stick them in there, so you can do all of your other cardiac arrest measures with the chest open. There's another tamponade. That one's really large. All right. So traumatic cardiac arrest. That's kind of what I just said. Why we use our resuscitative thoracotomy. So if they have traumatic arrest, as they present to the ED, we had vital signs or vital signs immediately before it, they lost an EMS en route for less than 15 minutes. Those are going to be good indications to do a thoracotomy. Penetrating chest trauma with witness signs of life during the transport during the ED is another indication that we want to do it, or they had electrical activity on arrival. Those are going to be good indications for resuscitated thoracotomy. And then penetrating abdominal trauma. These patients are going to need to get exploratory laparotomy. So these patients normally come in, we do a quick primary survey, and they go straight up to the operating room so they can open that belly up, and they can control any sort of hemorrhage and other injuries that they may have. All right, so yeah, if we can place these tubes, we like to do that prior to them going to the operating room, but sometimes they're in extremis. We may not have time for like a nasogastric tube, Foley catheter. We're definitely gonna have IV catheters. But what the bottom line is, don't delay any operative intervention, because those small measures aren't really gonna save that patient's life. It's gonna be opening up that belly, controlling any sort of hemorrhage that they have in there. Moving on to our secondary survey. So this is going to be our rapid, complete head-to-toe exam. And we don't start this until we've completed our primary survey. So we've addressed their airway, we've dealt with their breathing, and so we've intubated them, we've put a chest tube in, we've dealt with that. We've resuscitated them if they required any sort of blood products or fluids. We've evaluated for traumatic brain injury. We've completely exposed and rolled that patient. We've done our EFAS. We normally, I forgot to mention, during at the end of our primary survey, we get a chest x-ray as well, sometimes a pelvic x-ray, but for like testing purposes, chest x-ray would be part of our primary survey. So after we've stabilized that patient and resuscitated them, we're going to move on to our complete head-to-toe exam, evaluating for any additional injuries, fractures, sometimes minor things that we may not need to address right now. We want to evaluate for those during our secondary survey. And then here's kind of how it looks. We're going head to toe. So looking for any scalp wounds, bleeding, any facial instability, hemotympanum, any sort of facial trauma, avulsed teeth. Moving on to any penetrating chest trauma, like any sort of crepitus instability, looking at the pelvic, doing a good pelvic exam, checking for any sort of instability, crepitus, checking the urethral meatus, rectal exam, peripheral pulses, any deformities. We're going to look at immobilizing them at this point. So starting with scalp lacerations, they can bleed like crazy. So not to get in the weeds, but sometimes we do deal with this during the primary survey because of how profusely just a small vessel on the scalp can bleed. I'm not seeing it shooting across the room during the primary survey, so that's something we'll throw a quick suture in so we can stop that early. But if we haven't dealt with it at that point, then we want to look at any scalp lacerations and any clips we might need to place there. And then once again, we're reassessing head to toe, so looking for any hemotympanum, repeat our pupil exam, checking for any neck, thorax trauma, facial trauma. We might, if we have any signs of facial fractures, we may use an OG tube versus a nasogastric tube. And this is just to decompress the stomach, remove any sort of digested food or fluids that they may have in there, so that we don't have any risk of aspiration if we're going to take them to the operating room. This is when we're looking for any, blood at the urethral meatus. We're looking for any sort of, scrotal or testicular trauma, any rectal bleeding, any sort of those perennial injuries that we may not need to address during our primary survey. That's what we're looking for here. And if we have blood at the meatus, we need to evaluate their urethra prior to any sort of Foley catheter placement. So this one we do the retrograde urethrogram, or we call Dr. Evans so he can evaluate it first before we place any sort of Foley catheter in there. And then vaginal bleeding, we need to assess for any lacerations or any trauma that may have happened there as well. So we'll do, we may or may not do a pelvic exam with a speculum, or it might be a manual exam. during our secondary survey. And then we would check all the extremities, so looking for any bruising, crepitus. You know, we're looking for those more minor fractures that we may have to address at some point during our secondary survey. If the patient's stable enough, we'll get, you know, x-rays on all of their extremities. Then we want to do a more thorough neurologic exam if the patient is able, so we want to actually test, you know, our motor, sensory, and kind of address any sort of neurologic deficits they might have. That goes a little bit deeper than our GCS. So sometimes it can be difficult to tell any diaphragmatic injuries, you know, small bowel injuries, which are hard to diagnose. And then most frequently missed are going to be our spinal injuries. They're hard to evaluate just on your physical exam when you're palpating them, and so much going on in the trauma room. Getting a good neurologic exam can be difficult. And then after we complete our secondary survey, we move on to like our tertiary exam. Trauma patients that go to the operating room, a lot of times we don't do a complete secondary or tertiary exam until after we've operated on them and stabilized them. So this is something that we do during our in our trauma ICU. So you know, we may not identify these in the first 24 hours sometimes, and that's why it's important. One, you know, if you're on your rotations, doing a thorough tertiary exam once you've operated on the patient and stabilized them. But here's our quick kind of recap on things. So there's our primary survey, our X, A, B, C, D, F, G, stabilize, dress like threats, you know, resuscitate as needed. And then the secondary survey is going to move into like history, head to toe exam, any other imaging like, you know, extremities, pelvis, any other CT scans we may need. And then we move on to tertiary assessment on these patients once we've completed all that. All right, imaging. So we usually do like trauma labs is what we call them. So we usually run a giant rainbow of labs. So normally, initially we're looking at like blood gas, we're getting our CBC, our CMP, we're getting coags, we're doing a type and cross on these patients. We're looking at their urine, we're doing like a urine tox screen as well. So it's a giant rainbow of labs. And then for imaging, chest x-ray is going to be on everybody that presents usually the trauma room. We may get a pelvis initially at the primary survey. And then if we can get to the CT scanner, most trauma patients get what we call a pan scan. So it's going to be brain, C-spine, which is non-con, and then the rest is going to be chest, abdomen, pelvis, going to be contrast CT, evaluating for any sort of intra-abdominal injury. It also evaluates the rest of the spine as well with that exam for the pan scan. So most trauma patients are going to get them, especially with the right mechanism. And then, you know, our EFAS, which we'll practice during Block 5. I had a lot of questions. Block 5 is just all practice, like 5 minutes of lecture to show you landmarks. We do a quick demonstration, and you guys scan each other all day, every day for those classes. And then we do a performance examination at the end, which is pass or fail. The overachievers always said, like, we should get like a point grade, and I respond like, you guys would probably fail it if we did that. That's why we don't. Our goal is to get you, you know, not proficient, but proficient enough where you can perform the exam during phase 2. You know where the location, what you're looking for. Yes, you've only seen normals because you scanned each other, but so that you can be that person at phase 2 that utilizes it. And it is something, in the ER we use it every day for lots of patients. Other services are starting to utilize ultrasound, but that's how, you know, our Block 5 works. And like I said, CT, pan scan, secondary survey, we can get all those extremity radiographs that we need. Kind of address those. You know, our obtunded patients, really patients that meet that level 1 criteria, they're almost all getting a pan scan. So they're getting, you know, brain, C-spine, chest, abdomen, pelvis, to evaluate for any of those injuries, because we have the right mechanism of injury, so we need to make sure we rule those out or address. You know, it's hard to say rule things out, but we need to convince ourselves that they don't have those. Here's our labs. You know, it may change a little bit depending on what facility you're at, and I kind of talked about it already. So, got CBC, looking really at our hemoglobin level. We'll usually get ABG as well, or VBG on those patients, so because we can run it at the bedside with an iStat, evaluating that. CMP, our urine, ethanol level, pregnancy test. Those are kind of our common labs that we get on everybody. We want to get a D-stick or a blood glucose. We usually call it D-stick in the ER. You know, especially in any altered patient, we're going to look at that. And then in the right population, especially the older they get, we're going to get EKG and troponin on those patients as well. And then what's our disposition? So not every patient that presents to the trauma room has to go to surgery or be admitted to the hospital. There are, you know, a lot of times we can actually completely evaluate that patient, do our primary, secondary, tertiary, and if they don't have any significant injuries, we can sometimes discharge those patients home. If we identify anything, most of them are going to be admitted, at least for observation. Like rural hospitals, you know, these are patients we need to decide, like, do we need to transfer to a trauma center? And really, if we identify anything that needs surgery, they're certainly going to a trauma center at that point. And then everything else, our disposition is based on, you know, all of our testing, our physical exam, imaging, lab work, and then we decide where they're going to go, whether they need to be admitted to like the trauma service. Sometimes we may identify other injuries that were, you know, maybe orthopedics needs to admit them, that they don't actually admit, but they may need further orthopedic evaluation. I don't think you guys have covered trauma yet for surgery, but you will cover it, and we'll talk about difficult things to diagnose, or like pancreas and small bowel injuries are hard to diagnose on CT. So sometimes we admit them for serial exams if we have the right mechanism, until we can rule that out. And then head trauma, we want to consider admission for those, especially anybody with a GCS like below 14. We need to consider some sort of brain injury, and they might need to be observed in the hospital for a while until we can rule that out. Hollow organ injuries are difficult to diagnose. They may just stay. I know it's a lot. What questions y'all got? They're like, none except surgery questions. All right.